talking, I realized that the amount of time that I had left was decreasing from 17 minutes to 15 to 13 to 11, and at one point it was minus 5 minutes. And while the talk was going on, he kept saying, and Girish is going to show you this, and Girish is going to show you that. And so while he was talking, I gave up on trying to show the 3D demonstrations, and I thought I'll just show you some slides. And then he said, and then he's going to show you this, and he's going to show you that. So I've had to create a presentation for this session, and I think it's taken me much longer to do that than it's going to take me to actually do the talk. So anyway, so this is a form of 3D work that is called multiplanar reformatting. This is something that Dr. John Simpson is really strong on. He's from the UK, Evelina Children's Hospital, and John and I have been working together on a big 3D Atlas project that is going to be coming out sometime in this fall. But what you do with this is that you take this is a subcostal sort of a long axis acquisition, and that's the full volume. That's what that looks like. But you can have it displayed in a quad screen display like this, where and each of these lines here, you see this, the blue line here, and there's a red line there, and then there's a green square here, and then a green line and a blue line and a red square, and so on and so forth. What is happening with all of this is that you can decide that you want to partition the ventricle or look at a section that goes from here through the middle of that great artery. And then you also want it to go from the middle of the atrium to the middle of the RV, something like that. Because what you're trying to figure out is, what does the outflow tract look like between the ventricle, the ventricular apex, and that great artery? What does that look like? And when you do that and that, and these are, the cursors can be manipulated after you've acquired the full volume. So the full volume acquisition is a 4 beats acquisition. You acquire it, and then you can do all these manipulations after the fact. When you do that, it will basically show you the result of your manipulation in this image over here. So what this is showing you is a wide open aortic outflow tract. So that's kind of good news for this patient. The other part of it is, then you would end up taking this and similarly moving it from here to there, because that's going to be the plane of your patch. And you can see here already, this is going to be a problem. So you have to do these manipulations, and you can do these manipulations in multiple different planes. So for example, what I would have done here is move this red line over here, because I want to look at this hole in the orthogonal plane and see what that's going to end up looking like. Make sense? So this is one of the things that Norm was asking me for. This is again a full volume from Dr. Simpson's work. We've cut away the free walls of the right atrium and the right ventricle, and we're looking at the septal surface of the interatrial septum, the right atrial aspect of the interatrial septum, and the RV aspect of the interventricular septum over there. There's one outflow tract coming out there, another outflow tract coming out there. That's sort of the length of the outlet septum, if you will, that's between this artery and that great artery, and there's the VSD. So the idea being that from it's not easy with a 2D view to figure out the size and shape of these VSDs, and sometimes they look smaller than they are. And certainly I used to get fooled a lot by thinking that the surgeon would need to enlarge a particular VSD, and then they would go in and say, no, there was no need for that, it looked fine. Because we see it in this dimension, they see it in all dimensions. So this is a nice sort of a useful way to deal with that. This is another patient with double outlet right ventricle, where we're looking at a short axis view of the LV and the RV. And this is outlet septum between the one great artery there and this other great artery here. This one is the aorta, that one is the PA, and the VSD is over here. So basically this ends up being a subaortic VSD in a patient whose aortic valve is anterior to their pulmonary valve. All right. And I think with the kinds of things that Norm was asking me to do, I may have duplicated some of these acquisitions. But basically, that's that outlet septum there again, and that shows you one great artery, and that shows you another. So sort of similar to 2D imaging, but just a little bit more depth. And so what we what we do is we take the full volume and then we cut it into sort of almost the equivalent of a live 3D image. This is a live 3D image of a Tausig-Bing type of a double outlet. So the mitral valve is here, the LV, the ventricular septum, the aorta comes off. Oh, pointer gone again? Sorry. So here we go. Okay. Ventricular septum, the PA is large, the aorta is small. There's conus between the aorta and the tricuspid valve. There's conus between the pulmonary valve and both the AV valves. This is the sort of the septum or outlet septum between the two great arteries. You see a smaller aorta here, bigger PA there. That's the mouth of the RPA, by the way, that circle there. That's the content, and so the idea is this is very sort of a classic subpulmonary ventricular septal defect. And so the response here, the surgical approach here would be to close this and then do an arterial switch. This is an interesting patient that has a left ventricle here, a right ventricle there, ventricular septum there, a big huge sleeve of muscle between the inflow and the outflow, and difficult to show it to you from this projection, but basically that's one big artery there. You see those are the big leaflets of one, and then there was another one right there. So you can kind of see those leaflets there, this stuff here. So there's a small PA and a big aorta, and they both came off with no muscle between them. So there was there was complete continuity between the two arterial valves, and yet there was a big piece of conus between them and the AV valves. So that was interesting. It sort of matches up with one of the pictures that Steve showed and that Norm showed, I think. But still, I found it fascinating, this complete, in that sense you could call this subarterial, but subarterial relative to a VSD that's down there. So, it's a long way to being subarterial. So, and then this is an example of a patient with dextrocardia and superior inferior ventricles. So I just wanted to give you an example of the kinds of things that we want to look for in these patients. So this is the big aorta. There's a small PA there that's not usable. That's the right ventricle. This is the left ventricle. Mitral valve opening in. So usually in superior inferior ventricles, the LV is the inferior ventricle, and the RV is the superior ventricle. And usually with these, it tends to be a double outlet, just like this. One of the concerns in these is, does the tricuspid valve straddle? Is there a crisscross sort of a relationship of the AV valves? And what you see in this situation is that to get blood from the LV out to the aorta would be a straight shot. You just have to close this VSD over here and then put in a homograph. Make sense? So we're basically just looking down into the structure here to make sure that the pathway looks good. This is an old echo of a Lecomte. This is a grayscale plus color. So we've suppressed the grayscale now to show you the color. You see the branch PAs there. And then we're going to kind of turn this image around. So we're looking at it now from above downward. So the LPA is to your right, to your left, the RPA to your right. You can see that the red thing there is the aorta that's sort of going underneath the PA. So it's not just that the PAs gets pulled back, but the contour of the aorta also gets just a little bit altered by the Lecomte maneuver, which is something that's only obvious when you look at other forms of imaging. Typically not very, at least has not been intuitive to me to understand that by 2D echo. But here you can see the entire length of the ascending aorta. Oh, this is not even projecting with the light situation here. All right, and then this is SLL transposition, so congenitally corrected transposition, if you will. So RA, LV, LA, and RV, ventricular septum. So this is a TE from Dr. Simpson's lab. There's a ventricular septal defect. You can see the reversed offset, the septal attachments of the left AV valve, the trabeculated nature of the left-sided ventricle, the septophobic nature of the right AV valve. And I thought I'd just put this one up because it's lovely. It's an unfast presentation of both of the AV valves in this lesion. So you see a trifoliate left AV valve and then a bifoliate right AV valve. So this is a left-sided morphologic tricuspid valve. This is a right-sided morphologic mitral valve. And that's all I have. All right. Thank you. I got a question earlier about why I'm not talking about quantitation in 3D echo, and part of the answer is because I thought I would just save all of that up for the one talk on cardiomyopathy that's coming up day after tomorrow in the morning, because if I start to talk a little bit about it each time, I thought it would just be a little bit too difficult for me.
Thank you. So some functional aspects, and I'm going to talk about both complete and congenitally corrected transposition of the great arteries, and really overlap in a large part of the talk. And potential problems in a complete transposition and sometimes in congenitally corrected are coronary anomalies, which potentially can cause ischemia, valvular regurgitation, and residual lesions, all contributing to preload. Pulmonary and neo-aortic stenosis, more common, as Norman once said, but now less common, but still can contribute to afterload. Neo-aortic regurgitation we see in some of the patients. And I'm going to focus predominantly in the second part of the talk on the systemic right ventricle, because that's where we see many of the problems. So you know what a complete transposition is. And when I think of function, I try to connect it to the clinical scenario, as you've seen, and you can see that the outcome in complete or transposition is good, especially if it's a simple TGA. Patients do well after some initial mortality, and the outcomes are very good. These are the instantaneous risk, if you will, for mortality, and it plunges after the first period in life. So quite different from what we saw even regarding tetralogy. But still, there are obviously some patients who may have functional abnormalities. A small number had a decreased function. 13 required a pacemaker, which obviously can lead to dysfunction in the longer term. And if you look at the reasons for reoperations after the arterial switch operation, there are all kinds of problems that can affect ventricular function. So it's not a common problem, but it's certainly a problem in some of the patients. And here's one of these patients. This patient is already, at time of the echo, was 17 years old, and had a single coronary, as you can see here, from the right-facing sinus with an interarterial course, and developed some coronary artery obstruction after the switch. And you can see that there's mild dysfunction here of the septum, and tissue velocities, the systolic velocities were mildly reduced and needed some coronary tunneling. There's not a lot of data on strain because there's not a lot of dysfunction after the arterial switch operation. Here's one paper specifically looking at left ventricular strain from Scandinavia, and what this paper found was mildly reduced strain in all segments. But again, this is the type of data that we have at present. I think we have information on some reduced strain, but we don't really know what that means, and we know that long-term outcomes are good. So this doesn't, what do you do if you do find reduced strain in a patient? Do you follow more closely? Do you do something different? We don't at the moment. We don't routinely measure strain in these patients, but this is the paper that's out there. And this paper also found quite a significant decrease in basal rotation. So again, does that decrease left ventricular efficiency? Well, we don't see much clinical implication of that, but just to show you what's out there. This is an MRI paper from Henrik Kreutenhaus, who's actually in Toronto as a fellow right now, and he found some diastolic abnormalities, a delay in relaxation, but this was clearly related to pulmonary stenosis and an increased right ventricular mass in some patients. So that's just to say there are anatomical residual lesions that may impact the function. That's not too surprising. And he, in this paper, actually didn't find many systolic abnormalities. Norman mentioned the post-operative course and the potential for dysfunction. So I've shown you a few of these slides of the force-frequency relationship by IVA. And transposition patients can have quite significantly decreased function just as a result of the operation. And I think cardiopulmonary bypass plays a large role, even if they don't have frank ischemia, which obviously is going to lead to dysfunction. But really the issue that we need to talk about with function pertains to the systemic right ventricle. And the systemic right ventricle, as you know from the previous lectures and probably beforehand, is that you either have a systemic right ventricle in the setting of congenitally corrected transposition of the great arteries where the RV is left as the systemic ventricle, or in the atrial switch patients who have a complete transposition, and that was the operation that they underwent. And as opposed to the complete transposition, here there's clear data that many of these patients don't do as well, especially after the long term. And this is a paper out of Erasmus in Rotterdam, and very nicely showed that these patients don't do as well. And they don't do as well in terms of their functional class, their New York Heart Association, their ejection, right ventricular ejection fraction, this is MRI data, decreases, and this is related to a decrease, quite significant decreases in right ventricular function. So here the story is completely different, and the assessment of right ventricular function becomes very important. And this right ventricular ejection fraction, as expected, or is not surprisingly, is related to the deformation of the right ventricular myocardium. If you look at IVA, as Michael Vogel did in congenitally corrected transposition of the great arteries, and you compare the IVA to invasive measures of contractility, the end-systolic elastance, there's a correlation, but a large scatter. So this is change in IVA after dobutamine at catheterization, and there is some correlation, but a large scatter. You do see that these patients, at least in his study, it was a small subset, 12 patients, they do have systolic reserve. They could increase systolic velocities from 4.7 to 9.3, and the acceleration of the systolic wave as well. There's no control group here because these were patients that underwent cath. So some of them have systolic reserve. A bit difficult to take away from that data conclusions. Anyway, if you look after the Senning, again, as an example of the systemic right ventricle, it's quite clear that these patients have reduced deformation, either compared to the subpulmonary right ventricle in a normal patient or to the systemic left ventricle in a normal patient, because these are now systemic RVs. So you could ask what you compare it to. Whatever you compare it to, the strain is reduced, and again, correlation with RV ejection fraction over there. But what happens in patients that are asymptomatic, that haven't deteriorated to New York Heart Association class 4 or 3, where you'd say, well, I expect RV dysfunction there. Well, this is a paper from the last few years, again, a collaboration from the Mayo Clinic and guys from Nijmegen in Holland. And whatever functional parameter you look at, even these asymptomatic patients, and these are adults by and large, have right ventricular dysfunction. So the myocardial performance index, strain rate very significantly reduced, displacement and strain reduced. So I think these are quite significant results. In fact, over 80% had abnormal RV function. But as I've been telling you in every lecture, never forget the contralateral ventricle. So if we're talking about the systemic RV, there's an LV there as well. And I think the LV, just as I talked about in tetralogy, is particularly interesting. So 40% or more had abnormal LV function. Now, there are interactions between the ventricles in any situation and in this condition as well, because you can see that there's a correlation here, moderate if you will, between RV and LV strain. And if you look at the patients, I've highlighted this, that have pulmonary stenosis, so an LV, they're more dependent, or the correlation increases quite a bit. So you'd maybe assume that the ventricular-ventricular interactions increase in this situation. So patients that have some pathology, this may be more important. Their outcomes, this is from Gerhard Diller, who's now in London, originally from Germany, who showed that strain was related to outcomes. These are, statistical, as Norman used to say, following Mark Twain, lies, lies, and statistics, or something like that, lies, damn lies, and statistics. So, you can see the curves all over, but this is a single parameter. I don't expect, we always try and do this, a single echocardiographic parameter to predict life with. So we do it in, the global parameters, but there is a correlation, and strain at some cutoff values had moderate sensitivity and low specificity to independently predict poor outcome or deterioration with a hazard ratio of 1.3. Now, I think this is an interesting study because we talked about ventricular interactions in the previous slide, and we talked about exercise intolerance. This is a group that took patients with congenitally corrected transposition of the great arteries and exercised them. And if you look at the systemic ventricle, so the right ventricle, the morphologic right ventricle, here are the control patients. Here are the controls. Here are the patients. In all the slides, it's the same. And this is at rest, and then at increasing exercise, at 1 and at 2 watts per kilogram. And you can see that the controls increase their strain with increasing exercise. That's what you'd expect in a normal response. That's the systolic reserve. But there's a blunted response, or a mildly decreased response here in the systemic ventricle of controls. In diastole, which are these two bottom panels, the abnormalities are much more striking, in fact, than the systolic abnormalities. And if you look at the controls, these are tissue velocities, look how the controls increase their systolic velocities to fill faster, whereas the congenitally corrected transposition patients cannot do that. And this is regarding the systemic ventricle. But if you look at the subpulmonary ventricle, you ask, well, why is this response? Here again are the systolic strain and the diastolic velocities. And you can see here's the diastolic response of controls, totally blunted in the patients, and the systolic is vastly different. So it's not only the systemic RV, but it's also the subpulmonary LV, which is limiting these patients. And in fact, recent studies using diastolic strain rate have showed markedly decreased diastolic strain rate in the systemic ventricle and in the pulmonary ventricle of the subpulmonary ventricle of patients. And in fact, if you look, they found a correlation between the left ventricular strain rate, the subpulmonary left ventricle, and the eccentricity index, which gives some kind of measure of the ventricular interactions, one ventricle compressing the other. This is a busy slide, but I just wanted to go through it. There weren't good visual graphs of the slide. Again, work from Giovanni De Salvo from the last couple of years. And he also looked in exercise and trying to find data regarding the exercise. And you can see that METs here is the workload during exercise. He found a correlation between the transverse strain and the METs. But he also found a number of abnormalities in the distribution of strain and the strain pattern. And just to summarize this, and it will be in on the website and in the handout, he found that the base to apex gradient was abnormal here versus controls, just as I showed you in ASD and tetralogy of Fallot. And he found that the patients had an increase in transverse strain. Transverse strain is like the radial strain that I talked about, versus a decrease in longitudinal strain. Now, if we have time, which we don't because we're way over time, I'm skeptical about transverse strain where you measure it from a longitudinal direction. But nonetheless, you can think of this as radial strain. And this data is interesting because if you look at pressure volume loops, here is the pressure volume loop of the left ventricle that I went over earlier today. Here is a pressure volume loop of the subpulmonary right ventricle. There's hardly any isovolemic contraction time. You can see here a decrease in volume implying ejection. Then there's a fall in volume as the right ventricle ejects. And then there's hardly any isovolemic relaxation time as the ventricle fills immediately. So this is a trapezoidal or triangular shape versus the square loop pressure pump of the LV. Now this is pulmonary hypertension, but the RV facing systemic pressures. This is what happens, and this is work of Andrew Reddington. This is what happens to the RV when it adapts to systemic pulmonary pressures. So it becomes it adapts, if you will, to an LV type pressure volume loop. And the contractility, you remember that end systolic pressure volume slope, the slope of that relationship that I showed you yesterday goes from this to that. And so when you take a systemic RV, or you take an RV and you ask it to act in the systemic position, perhaps it needs to adapt. And this is very interesting echo work from a few years ago, again, the Scandinavian group, showing how the normal RV goes from a longitudinal to a more circumferential strain pattern. So longitudinal strain decreases, circumferential strain increases. These are just the numbers. I won't go through them, but you can see the patterns over here. These ventricles, however, don't have torsion. They don't twist in the same way as the normal left ventricle. But perhaps this is what the RV needs to do to adapt, to become a successful, if you will, systemic RV. I think the jury's still out on this, and I think the strain data is still very early, and I'm not sure about that transverse strain, but it may explain some of Giovanni Di Salvo's results, and that's interesting. These are just a few examples that I took images that we had already acquired with DICOM and used this program on it, on DICOM images, not on raw data. And you can see here, this is the short axis views, patient with congenitally corrected transposition. Sorry, this won't play. But what you can see here is you can follow the VVI in the radial and in the longitudinal direction. And in here you can see reduced septal circumferential strain, which is this red dot over here. And over here, again, in the longitudinal direction, if you look down here, there's reduced strain in both ventricles in a patient with poor LV function. Here's a patient with congenitally corrected transposition of the great arteries that has apparently good RV function, but again, very reduced longitudinal strain. So the abnormalities that we may not see visually with the naked eye, or we may not appreciate. So I'm going to stop over there, and thank you.
Got it. Right, so transposition of the great arteries. So it's really one phenotype, but as Dr. Silverman and several of the other speakers have alluded to, we end up with two different physiologies depending on what surgical correction was performed on the patient. The mustard and ascendings, which leaves the RV as the systemic ventricle, and then the atrial switch, which has the coronary transplantation along with the keeping the native pulmonary valve as your aortic valve. So depending on those two, you're going to have a very different cardiac evaluation. So I will show you that as we go along. We all know the transposition physiology, the parallel systems that cause the trouble with the cyanotic blood remaining in the aorta and the oxygenated blood being on the pulmonary side. I think of the atrial switch. I know Dr. Silverman showed you guys the mustard and the settings and the differences, but I really think of it as a pair of pans. And if you think of the pans, the leg part of the pans being the IVC and the SVC, and then you have a long trousers sort of thing with a belt around the mitral valve. I find that's very much easier to sort of understand the anatomy. So the area of the belt around your waist is really sewn around the mitral valve, allowing it to be the trousers. And the pantalon, as was initially described, lets you have the IVC and SVC with the blood flowing across that. And then you've got an obligatory atrial septal defect that allows the pulmonary veins to go into the right atrium and then into the right ventricle. Obviously, the arterial switch is much more going back to a normal anatomy that we think of, keeping the same valve tissues. So you have the native pulmonary valve in the aortic position and the native aortic valve in the pulmonary position, which causes its own problems. Just as a bit of history, the setting and the mustards were really started in the late 1950s, early 1960s. The arterial switch, depending on where you were around the country, both in the United States and here in Europe, depending on where you were, some centers continued doing the settings and the mustard well into the 1980s until the arterial switch got better and finally were switched in the late 1980s and early 1990s to everybody being done more in the arterial switch. Obviously, the Rastelli operation was mentioned for patients who have subvalvular and valvular pulmonary stenosis, where the pulmonary valve, the native pulmonary valve, can no longer be used as the aortic valve. So let's start by the atrial redirection surgery, or the mustard and the Sennings, and what can be done with the cardiac MRI. Obviously, we've talked about the biventricular volume measurements that we've gone through, the ejection fraction, stroke volume, and diastolic volume and then systolic volumes, both for the right ventricle, which is the systemic ventricle, as well as for your left ventricle, that's the pulmonary ventricle. You can also look at assessment for stenosis and regurgitation of both of the valves. And then the more important thing is assessing your IVC and SVC for any kind of stenosis, assessing your pulmonary vein baffle for any kind of leaks or stenosis as well, and assessing for a QPQS to see if you have any leaks in any of the locations. We can also look for presence of scar tissue, the late gadolinium enhancement, and once again, this can play a big role in having any kind of abnormal rhythms. So here's an example of the mustard and the Sennings. You have the SVC here and IVC here, entering into the ventricle, the left ventricle, and going out to the pulmonary area. You have the venous blood returning into the right atrium, into the systemic right ventricle. And you have what the pathognomonic for transposition is, the parallel great vessels. You've got the PA here and the aorta here, which is a classic image that's often seen on American boards for this. You could do the MRA twist that I was telling you before, where you give the contrast, and I've shown you each frame so we can follow it. You can see the contrast entering through the SVC. Obviously, we don't see the IVC because the contrast is given from a brachial vein, entering into the baffle, into the left ventricle, and then from the left ventricle entering the PAs, pulmonary veins, returning via the pulmonary veins, confluence right here into the right ventricle, and then out the aorta. And I'll show another example of that, a little more images, same thing, and you see the right ventricle here into the aorta, a trabeculated ventricle. Here's what this looks like when you actually play it. And you can see the very bullet-shaped left ventricle initially, and the more circular trabeculated right ventricle at the end. And the reason you want to sort of watch this is you want to study the function of and you can see here the trabeculated right ventricle being the circular versus the more moon-like left ventricle that's being pushed over by lower pulmonary resistance. You can study the SVC and IVC connections. Here you see the SVC very nicely entering. There's no stenosis anywhere along the SVC, and it's widely patent. You can also look at the venous connections. Here you see the pulmonary vein coming in, as well as here. This is sort of cut into the beginning of a valve, but if you look down here, you can see it's widely patent. Same patient, widely patent here, ASD, no restrictions, there's no leaking of any of the baffles, and you have the systemic right ventricle here. You can see it's hypertrophied as it should be across that. You can also see the RV to aorta outflow tract through that same position. The reason that's important is that you'll find patients that have IVC and SVC obstruction. Here's a patient with some IVC obstruction. Here's a patient with some SVC obstruction. And so you can take them then to the cath lab and potentially put a stent in there. Here's a stent to the SVC, opening that up. And here's a stent in the IVC, opening that up. Here's another example of a patient that has a good setting mustard. You can see again the parallel great arteries. Here's the aorta, the pulmonary arteries still in their normal location, the aorta being anterior. And here is again what we see by echo, very pathognomonic. Both great artery valves are seen in one plane. And here's sort of all of those same exact information in one kind of slide, letting you see all the different information showing a post-op study that is actually quite normal. As was mentioned, we can look at the coronary arteries. This patient specifically had a single coronary artery. You can follow the track and see if there's any stenosis along that. So CMR after atrial switch is very helpful in looking at the different baffles, making sure there's no leaks, and making sure that they're widely patent. We can also use a cardiac MRI to look at patients after arterial switch operation. We have similar goals in the arterial switch, but obviously the anatomy is going to be very different. And we're specifically going to look more at the supravalvar area, where the anastomosis that the surgeon left after switching the valves or the arteries. And the other thing that you potentially have to look at is the Lecomte maneuver and making sure that the branched pulmonary arteries are not stenotic. So here's a patient that had arterial switch. And what you want to look at here is you see both of the ventricles are actually quite hypertrophied. And so you begin to wonder, why is there such hypertrophy of the right ventricle? The aorta seems to be widely patent with no trouble. But then if you look a little further and more closely, that explains why the pulmonary valve is not working well. It's small in the supravalvar area. And then when you see it just above the valve, you can see that there's quite a bit of stenosis here. And so this right ventricle is working under higher pressures and has become hypertrophied from that. You could do a velocity encoded image on there. And you can see the small pulmonary valve. And then with the velocity, you can see how it does not open very well. You could look at the branched pulmonary arteries by the same technique. Here's the right pulmonary artery, widely patent. Here's the left pulmonary artery, also widely patent. At times, though, the right pulmonary artery is not as widely painted. You can see here in the Lecomte maneuver, the aorta is in the center, the RPA and LPA sort of split across that. Here's the SVC, and you can see the RPA is coming across in between the two and can potentially get squeezed. Here it is again in more of a coronal image. So here you can see the RPA that's small and being squeezed between the SVC and the aorta. You can take a look at this by looking at the branch pulmonary arteries. You can see the SVC would run right around here. And you can see that there's lack of contrast entering in that location. Here's that same image, and again, you can follow it and watch as the branch pulmonary arteries get filled. We can study the coronary arteries like I showed before, especially abnormal. So here's normal coronary arteries. You can see very nicely, widely patent, and look very well. And then you can see abnormal coronary arteries. Here's the circumflex coming off of the right coronary artery. Lastly, you want to look at any kind of tissue abnormalities. This can be occur during surgery, or as we know now, also post-surgical repair. This is pretty much having a myocardial infarction from a coronary abnormality that was an embolus, presumed embolus. So you can see almost a transmural in some location, but kind of a subendocardial myocardial infarction. And that can have a huge effect on the ejection fraction of the ventricle. So for very similar reasons as before, the volumetric measurements and stenosis of the branch PAs, you can take a look by cardiac MRI. I wanted to show a couple of images actually of left transposition of the great arteries, which we haven't really spoken about very much or congenitally corrected. So here's the telltale sign. You've got your aorta in the anterior leftward position, and then the branch pulmonary arteries here, SVC, descending aorta, and you can see they're widely patent. Again, you can see the abnormal relationship of the ventricles, and then the abnormal relationship with the conus right here of the mitral valve up to the right ventricle up to the aorta. You do a twist of that as well. And so you can study the left LTGA, in this case, relatively unaffected LTGA, but they can obviously come with VSDs and subaortic and subpulmonary stenosis. That's it.
So we're going to move on and try and talk a little bit about Truncus Arteriosus. And again, remember the abnormal rotation of the outflow tract that's associated with many of these conotruncal anomalies. This is an example of persistent truncus that was published by this group This is a mouse model in which they were able to induce abnormal rotation of the outflow tract and show that, in fact, tracing this somaphorine protein shows an incomplete rotation here that was associated with truncus. Now, truncus was the sort of the classic defect created by neural crest ablation model that Dr. Kirby developed, 30 years ago, I guess, 25 or 30 years ago now. Anyway, the neural crest cells delaminate from the neural plate up here on either side of the developing neural tube, the junction between the ectoderm, the skin ectoderm, and neural ectoderm, and then migrate down through very specific pathways in each of the pharyngeal arches, beside the pharyngeal arch vessels, and eventually end up in the heart. But they do a number of things probably in the pharyngeal arches before they actually get to the heart. Neural crests, as we said, are important not only for, as we'll see, for closure of the outflow tract septum, but they also contribute most of the smooth muscle to the ascending aorta, to the main pulmonary trunk. And there are a number of factors that are involved in guiding these. These are very programmed, specific pathways that the neural crest cells have to travel in. Otherwise, they don't reach their proper destination, and so we get congenital heart defects. And there are a number of guiding proteins here, neureglins, somaphorins, ephrins, all of these things that we know from neurology and neurodevelopmental studies, that these guide axons to go where they're supposed to go. They do the same thing for neural crest cells, which are nerve cells also, but they do the same thing for vessels as well. So these are guiding proteins. There are a number of ground substance proteins that are cell adhesion molecules, cadaverins, catenin, connexins, that are important for normal expression of these, are essential for allowing the neural crest cells to be able to move, to enable their mobility as they travel through the pharyngeal arches to get to where they're going. So there are a lot of opportunities for abnormalities to occur. And as we saw before, these migrate into the outflow cushions or outflow ridges here, and you can see the neural crest cells here shown in blue concentrate in the center and are responsible for fusing the outflow ridges to create the outflow septum. And then this rapidly undergoes remodeling to create vessel walls, and these neural crest cells then transform into smooth muscle cells and actually supply most of the smooth muscle for the ascending aorta and pulmonary trunk. But they also interact with pharyngeal mesoderm. This is a photomicrograph showing a POX3-Cre. It's a way of actually staining cells that have ever expressed the POX3 factor, which is a marker for neural crest cells, and they're shown here in green. The red cells, the red staining cells, are just pharyngeal mesoderm cells. But you can see how the neural crest cells are in very close contact in many places with pharyngeal mesoderm cells, and there's probably a lot of signaling that's going on here between these two cell populations. Notch signaling, fibroblast growth factor signaling, that's essential for normal development of the pharyngeal mesoderm, which is really the second heart field. These are the cells that are going to grow into the outflow tract and contribute the myocardium to the outflow tract, or much of the myocardium to the outflow tract and to the right ventricle. And this is what we were talking about today. There's some interaction here between neural crest cells and the pharyngeal mesoderm that's going to be right ventricular myocardium that may be very important for normal right ventricular function. And in many of these neural crest phenotypes, and there are a lot of causes of the neural crest phenotype, not just ablation of neural crest, but there are a lot of things that can cause this kind of phenotype, interfere with this interaction between neural crest cells and the mesenchymal cells in here that are going to move into the heart tube and become myocardium. Things like TBX1 deficiency. TBX1, interestingly, isn't even expressed in neural crest cells, but it's expressed in the mesodermal cells and endodermal cells in the pharyngeal area. And this is a very important factor. This interacting with fibroblast growth factor signaling. This is very important for maintaining a balance of enough proliferation of cells in this second heart field to allow enough cells to grow into the outflow tract, and yet not having so much proliferation and not enough differentiation and movement. And so there's a very tight balance between these factors, and just the dosage of both of these is very critical. Small changes in the dose of either one of these in this particular area can cause this phenotype. And there are a number of other, the PAX3 is important for neural crest cells being able to mature and move into position. The somaphrin is another molecule that's important for guiding neural crest cells. Retinoic acid is very important in this area. And then the charge gene, the gene that's responsible for most cases of the charge anomaly, can also produce the same type of phenotype. So this is just a little introduction to the things that are important for development of truncus that we know about. And the definition of truncus, again, Marshall Jacobs, one of our surgical colleagues, who they've kindly provided us with definitions of congenital heart defects. It's an uncommon defect where there's a single arterial trunk that gives rise to the coronary arteries, the pulmonary arteries, and the systemic arterial circulation in that order. That's the important thing that distinguishes it from tetralogy of Fallot with pulmonary atresia, for example. So most of these have a VSD and a single semilunar valve. Virtually all of them do. I don't know that I've really ever seen one that didn't have a VSD. The infundibular septum is absent in most of these patients. There's a single semilunar valve that can have multiple leaflets, anywhere from 2 to 4 or even 5. They're often dysplastic valves, and the semilunar valve overrides the septum, and there may be dysfunction. So we can think about truncus in sort of two major types, one where there's a large aorta and one where there's a large pulmonary artery. Okay? Of the large aorta type, there are two types that are very similar where the pulmonary arteries are essentially confluent. There's either a little short main pulmonary artery or there isn't. The two branches derive just next to each other from the ascending part of the truncus here. So these two are very close. They're treated the same way, basically, surgically, and they're very close together. The other important type here in this large aorta group is one where there's an isolation of a pulmonary artery. One of the pulmonary arteries arises from the truncus in the same way that these do. The other one is isolated from the ductus and arises from the ductus. It can be either one that does this. It's usually the one opposite on the side of the arch that does this. And then the other type, the large pulmonary artery type, is where there is an interruption of the aortic arch, a small ascending aorta. The pulmonary trunk is very large. There's a large ductus that supplies the descending aorta. It's usually a type B interruption because this is usually DeGeorge syndrome, which is the type of aortic arch interruption that's usually associated with DeGeorge syndrome. So these are the main types of truncus that we see, and we'll try to look at examples of this. The physiology basically is a large overriding root that receives ejection from both ventricles. So there's mixing in the truncus in the ascending aorta. There's a left to right shunt because the pulmonary arteries are connected to the truncus, to the ascending aorta, so both systolic and usually diastolic flow into this like in a ductus, only it's a big ductus. These patients have variable dysfunction of the truncal valve. Sometimes it's quite regurgitant, sometimes it's not. Very often you can measure a gradient across this valve, either by Doppler or at catheterization. And it's important to remember that there's usually a lot of excess flow across the truncal valve. So most of the gradient that you measure is really flow related and isn't really because of anatomical stenosis. I mean, if there's 2 or 3 or 4 to 1 QPQS, as there often is in these patients, then you have that many times the normal amount of flow going across this truncal valve. and it's very easy to develop a 20, 30, 40 millimeter gradient that once you fix it goes away because it's really flow related. It's possible, having said that, it is possible to have stenosis of the truncal valve, so don't ignore it altogether, but keep in mind the possibility for having flow-related gradients across the valve. And then heart failure can occur particularly in patients who have a lot of truncal valve insufficiency, and these patients are at risk for early development of pulmonary vascular disease. So here's an example. Here's our big truncal root here. That's opened. Here you can see the truncal valve down here. This is the aortic part. Here's the aortic arch coming up here with brachiocephalic arteries. And here's the pulmonary trunk. There is you can close this up and create a little pulmonary trunk over here that has a little bit of length to it and then gives rise to the right and the left branch pulmonary arteries. So this has a real main pulmonary artery segment that comes off from the truncus. And here's the truncal valve, their coronary artery there. Here's one leaflet, there's another leaflet, and here's another coronary ostium up here to show one of the things that happens in truncus, and that is that the coronaries can come off above a sinus of Valsalva or even behind the leaflets as they attach at the commissure. So here's our truncal valve, our truncal root up here. Here are the brachiocephalic arteries. Here you see a carotid, another carotid, a subclavian. This is a right aortic arch, and this patient has an aberrant left subclavian artery. So this is an aortic arch anomaly, right aortic arch with an aberrant left subclavian behind the trachea and the esophagus here as it would be. So this is very likely that this patient has DeGeorge syndrome. And you can see this is just an aberrant subclavian. There's no ductus associated with this, no diverticulum of Komarov. So this is just like an aberrant right subclavian in a left arch. It usually doesn't cause any respiratory symptoms. So here's the inside of the right atrium, atrial appendage up here. Here's the foramen ovale down here, tricuspid valve into the right ventricle, septal leaflet of the tricuspid anterior leaflet there, and down here the inferior leaflet. And then when we open the right ventricle and look inside, you see the VSD here. Here's the Y of septal band. Here's the body of septal band here. This is the inferior ramus with papillary muscle of the conus, superior ramus there. This is all muscular border here. There's no involvement of the membranous septum here. And here you see the leaflets of the truncal valve up here. And in this case, I think there are three. The truncal valve overrides the septum through this ventricular septal defect. Here's the left ventricle with the mitral valve here, anterior mitral leaflet, free wall papillary muscles. You can see how dilated this ventricle is because of volume overload of the left ventricle. There's a smooth septal surface up here of the left ventricle and the outflow to the truncal valve from here. There's mitral to truncal valve continuity in this patient. So here's another patient. Now this is a little bit different. Here's one branch pulmonary artery, there's the other. They come off right next to each other from the trunk here with little or no main pulmonary artery component to the truncus. Inside the right ventricle, we see again the tricuspid valve, the superior leaflet here. Here's the septal band, the inferior ramus, superior ramus, and the VSD is typical of truncus in the Y of septal band. Truncus is really very consistent in this regard. Here you see the smooth septal surface in the left ventricle, free wall papillary muscles here, the anterior mitral leaflet there, and it continues with the truncal valve leaflets above. And here with the septum cut here, you can see how the truncal root overrides the interventricular septum. And here you see one leaflet, and there's another leaflet there, and then there's another leaflet that's been cut. There's part of it there that's been cut, and the other half of it's over here. So this is a 3-leaflet truncal valve. Now here we have a type 3. Here's the truncus. Here's the ascending aorta over here. And here, there you can see the left pulmonary artery that arises from the truncus here. There's only the one pulmonary artery arising from it. Here's the aortic arch over here. And you can see it's to the left of the trachea. There's the trachea here. Here's the brachiocephalic artery that's going to go back to the left side. Sorry, it's going to go to the right side in the left arch. And here you can see a ductus coming from the base of the brachiocephalic artery here that goes down to the right pulmonary artery here in the hilum of the right lung. And now this used to be a ductus, but in fact now it's a ligament. This patient's pulmonary artery has been lost because in this type, that's what often happens if it isn't recognized early on and something done about it. So here's the ventricular septal defect, the papillary muscle of the conus, inferior ramus, superior ramus, and the VSD under the truncal valve. And there's the left ventricle with mitral valve, mitral to truncal valve continuity here, and again the overriding truncal valve muscular inferior border back here that's very typical of truncus. So just to save a little time, we'll go on. This is a type 4. This is an interrupted aortic arch type. Here's the ascending aorta, which is quite small here. There you see the innominate artery, the carotid artery, and then here's a large pulmonary portion of this trunk. The aorta is sort of an afterthought over here, stuck on the side of this big pulmonary artery. And here you see the VSD. Here's the pulmonary trunk. Here's the right here and left pulmonary artery, and then the ductus up here continuing into the descending aorta because this is an interrupted aortic arch. And the left subclavian is there. This is a type B interruption between the left carotid and left subclavian. So there's the subclavian coming from the descending. And here we see the truncal valve. There's 1 leaflet, 2, 3, and 4 leaflets. So this is a 4 leaflet truncal valve that is one of the types that we see. Just to look at a couple of other examples of truncal valve, here's a bicuspid truncal valve. You can see the 2 leaflets there, the 2 commissures. There's 1 commissure here, 1 commissure there, the 2 leaflets. There's a raphe back here on this leaflet. Here's a big coronary artery there. Here's another quadricuspid aortic valve. There's that one, and there's the 4th leaflet there. So management of this, early medical management with diuretics. Some people have used vasodilators in this to treat heart failure, but mostly diuretics to get patients in condition for surgery and repair early in the first weeks of life. And the repair is done by simply separating the pulmonary arteries from the truncus, creating a pulmonary outflow tract, usually with either a conduit or a homograft or direct connection of the pulmonary arteries to the right ventricular created outflow tract with hooding with some kind of prosthetic material, VSD closure just to the truncal valve so that it all goes into the left ventricle, and sometimes a truncal valve replacement if the truncal insufficiency is really severe and can't otherwise be treated. And that's about it for truncus.
Okay. As you can imagine, with Truncus Arteriosus, where there's a common trunk arising from the two ventricles, there is a large ventricular septal defect. So left and right ventricular pressures are equal, and they behave as in tetralogy GFLO, where there's a very large ventricular septal defect. Now, in the fetus, we know nothing about what venous patterns are like, but we can assume that they're probably normal because the atria are relatively normal, and there's a normal foramen ovale, so that probably the venous return patterns are normal. Now, in Truncus, as Dr. Sanders described, there is complete admixture in the truncus of blood ejected by the right and left ventricles. Now, this is not entirely true because in type 1 truncus, where the pulmonary artery comes off very close to the truncal valve, and it's a common pulmonary artery, there may be some selective streaming of blood, so that right ventricular blood is ejected preferentially into the pulmonary artery and left ventricular into the other part of the truncus, which goes up the aorta. So that because of that, it's quite common when we used to catheterize these patients, in the baby, you would find that the oxygen saturation in the aorta was as much as 5 to 8% higher than in the pulmonary artery. So that there may not be complete admixture. In types 2 and 3, though, where the pulmonary artery comes off somewhat higher away from the truncal valve, that doesn't happen. So it's only in type 1 that you may see the selective thing. Now, the complete admixture, you can imagine that you can get some rough idea of what the total mixed oxygen saturation will be, because if you know the oxygen saturation of umbilical venous blood, the oxygenated blood, and you know the oxygen saturation of venous blood, and you know the quantities of these flows, you can easily calculate what the final mixed oxygen saturation would be. And I've done some calculations based on what we know about the magnitude of umbilical venous flow and what we assume is umbilical venous oxygen saturation, that the mixed oxygen saturation is going to be somewhere around about 53–55%. This would mean that there would be a somewhat lower oxygen saturation of blood going to the brain and a somewhat higher oxygen saturation of blood going to the pulmonary circulation and to the descending aorta. Whether this has any impact on development, we really don't know, but there would be this small change in oxygen saturations. Now, in Truncus arteriosus, the ductus arteriosus is usually absent, may be present, and of course it's obviously present when there is the so-called type 4 truncus, where there's an interrupted arch because blood to the lower body is carried through the ductus. Now, I've mentioned this, that there is the streaming of blood. One other important thing is that in Truncus arteriosus, of the type 1 truncus, there is never any pulmonary stenosis. But in types 2 and 3, it's quite common that the orifices of the pulmonary arteries are somewhat stenotic. And this is important because as we go along and talk about the impact of truncus, is that after birth, when pulmonary vascular resistance falls, there's going to be a tremendous increase in pulmonary blood flow. Now, this increase in pulmonary blood flow is very dramatic in type 1 truncus because the pulmonary arteries are large and they can accommodate this large flow into the pulmonary circulation. So that in type 1 truncus, it's very common to develop cardiac failure very soon after birth. In types 2 and 3, because of the fact that the size of the pulmonary arteries is often somewhat limited, and because of the fact that there may be some stenosis at the origin, they do not as readily develop cardiac failure because their pulmonary blood flow does not increase as much. So therefore, the volume load on the ventricle is not as dramatic. Now, as I mentioned, there's complete admixture of pulmonary and systemic venous blood, as well as in the systemic arterial blood, not venous blood, so that in the truncus, the final saturation is going to depend, again, with a complete admixture, it's going to depend on pulmonary to systemic blood flow ratio. So that early after birth, before pulmonary vascular resistance has fallen dramatically, the pulmonary blood flow is not so high, so the oxygen saturation is somewhat lower, and these babies will appear blue. But as pulmonary vascular resistance falls, the increase in pulmonary blood flow is really dramatic, especially in type 1, and they get such a high oxygen saturation that they may not even look cyanosed. They look quite pink often because of the high pulmonary blood flow. Now, one other important thing about truncus is that it's really surprising. You'd expect that they would behave like a ductus because this huge pulmonary blood flow comes from the aorta, so you would expect that they would have a very large pulse pressure and bounding pulses. The interesting thing is, though, that they often do not. Occasionally they do, but most babies with Truncus Arteriosus do not have bounding pulses. And I don't fully understand why it is, but I think the reason is they have low diastolic pressures, but the systolic pressure often does not become high, and I think the reason for that is that they have such a large runoff into the pulmonary circulation that they do, and such a large, the truncus, where in type 1 particularly, the vessel is very large, and I think it accommodates a large proportion of the output of the ventricle so that they do not develop a high systolic pressure. And I think that's why they do not have bounding pulses. But it's interesting, I've always had trouble in understanding why, but I think the reason is not because of the fact that they don't have the runoff, but because their diastolic pressures are low, but because they don't get a high systolic pressure. So the other interesting question is what happens with coronary blood flow with a low diastolic pressure, because here you have a situation where these babies have a huge volume load on the left ventricle, so the left ventricle is working, both ventricles actually are working very hard. They need increased coronary blood flow, and there's probably a limit to coronary blood flow. Not only that, but one of the interesting things about truncus is that there's a very high incidence of coronary artery anomalies. A very high proportion of them have some disturbance in coronary circulation, apart from the low diastolic pressure. So I think they are very compromised in terms of developing adequate coronary blood flow. Now, as I mentioned, in types 2 and 3, they may not develop failure because they don't develop, quite often do not develop these huge pulmonary blood flows and therefore do not have the increased volume load. Now, one of the interesting things about truncus is because of the fact that they may have 2, 3, or 4, sometimes more cusps. There's a very high incidence of truncal valve insufficiency. It varies in degree from minimal to quite severe. Now you can imagine that this imposes an enormous load, because if you have this high pulmonary blood flow plus truncal valve insufficiency, the volume load on these ventricles is going to be enormous. And this is why these patients, babies with Truncus Arteriosus, often develop very early cardiac failure, especially if they have significant truncal valve insufficiency. Now, truncal valve stenosis is not common. It does occur occasionally, but the important thing about truncal valve stenosis is that in the fetus and newborn, the ventricles do not tolerate increase in afterload at all well, because the muscle is not capable of generating force to overcome afterload. So the fetal and neonatal ventricle is very sensitive to increased afterload. Now, since truncal valve stenosis is affecting the output of both ventricles, if it's significant in the fetus does not survive. Postnatally, it presents a serious problem as well, and it become an important point about it is that after birth, because pulmonary blood flow increases so much, the volume ejected by the ventricles increases, which makes the stenosis even more significant, and they do not tolerate it at all well. That's it. Yeah.
Oh, I know.
How about that? Okay. All right. Thank you. I will try and do this as quickly as possible. I know everybody wants to get out of here, nobody more so than myself. So we'll just talk a little bit about Truncus Arteriosus. This is a picture from Children's Hospital in Boston. The old classification of Collett and Edwards, which is the first classification, is no longer used. We like to use this classification as type 1, type 2, type 3, and type 4 Truncus Arteriosus. And I'll use this as a form of illustration as we go through. Now, the goals of imaging the truncus after birth are to define, obviously, the type of truncus, define the morphology and function of the truncal valve, determine the presence of ostial stenosis or branch pulmonary stenosis, and I think that Dr. Rudolph's concept of the fact that the more distal the vessels are, the greater the likelihood that they are going to have some degree of stenosis early on is a very interesting and thought-provoking comment. Define the type of interventricular communications, estimate the pulmonary blood flow, and define associated lesions. We should also look at the aortic arch laterality and continuity and other anomalous vessels that arise off there. And obviously, most importantly, check for the presence of a patent ductus. Although it's uncommon in Truncus Arteriosus, it does occur, but most of the time when there's a ductus, it usually means that the aortic arch is interrupted. So let's just have a look at a couple of trunks. Here's a Truncus Arteriosus, and I'll use the pathology picture to just highlight the echocardiographic continuation. This is a parasternal long axis view. Here's the truncal valve. Here's the aortic arch. Here's the left pulmonary artery originating off the truncus. You can see this from the subcostal view. We can magnify and look at the truncal valve, which is frequently abnormal. and I'll talk a little bit more about that. And we can look at the origin of the truncal vessels as they come off the aorta. And again, once again, I would emphasize the use of multiplanar imaging as doing it. And here I've just turned this around so it corresponds to the picture. So from a different point of view, you can get corresponding images of the truncal vessel. So I hope this is going to work. Here's a fetal Truncus Arteriosus that I got from Andrew Cook in London, and shows very nicely the ascending, the whole truncal vessel here, with the truncus overriding the the ventricular septal defect and the ventricles, and the origin of the truncus coming off as a separate vessel with the origin of the right and the left pulmonary artery and the rest of the aortic arch here, which is kind of small. So here we start looking at the truncal vessel. The override is not a problem. You see the origin of the left pulmonary artery, and we start to see the origin of the ascending aorta. Change that around so it looks just like the image that we saw before. Now let's look at the septum between the aorta and the pulmonary artery. Frequently there's a little aorta pulmonary septum that develops a little ridge, which you can see pathologically. Here you see the truncal vessel as it comes by, and then the separation into the pulmonary artery and the aortic component of the truncus as we come more cranially in this area. And we can look at the branch pulmonary arteries, and also, I think very importantly, looking at the coronary arteries. And I'll spend a little time, although that's not, it is a congenital coronary anomaly, but I think that it's very important, as we've had this discussion, to say a few things about it, to perhaps try and understand some of the reasons why these patients have such a poor outcome. Now, when you look at the truncus at the back, remember this VSD is anteriorly situated, usually cradled in the arms of the septomarginal trabeculation or the septal band. And so when you look posteriorly, the septum is intact. And what this means for the surgeon generally is that the conducting tissue is spared, and it will not be a problem in terms of the ventricular septal defect patch, that there's nice strong area to put the patch on the muscle. And of course, this patient has also got some left ventricular dilatation and mitral regurgitation as a consequence of that. Now we scan it subcostally very usefully from a caudal to a cranial direction. And when we caudal, we see the pulmonary arteries, a bit of the truncus, we see the right pulmonary artery, and we see the left pulmonary artery coming off more anteriorly here in this particular view. So you can just look at a cranial caudal scan to see the various aspects of the truncus as we scan it. Now, looking here, you can see the truncus overriding the two ventricles, and here is the origin of the right pulmonary artery going behind the ascending aorta, and a little bit of the left pulmonary artery identified coming out on this side here. We can turn it around in the opposite direction and look at a sagittal plane image, and you see the origin of the pulmonary artery coming fairly close to the aortic valve here. And of course, this is a surgical caveat here, because the coronary artery rises very close to the truncus, and the surgical correction of this lesion requires that the surgeon takes the truncus off over here, and if the coronary arteries are arising high, as they do in this area, it makes a very important risk factor for the left coronary artery in this condition, particularly in type 2 truncus. And again, you can see the large left to right shunt with the incompetent atrial septum here, and the filling of the pulmonary artery off the back of the aorta with the color flow. Now, as far as the truncal vessel is concerned, I think it's fair to say that often it's very abnormal. The dominant feature of the truncal valve is a tricuspid valve leaflet, as you see here, but it's occasionally quadricuspid, as you can see here, and may also be bicuspid. I've never seen 1, I've never seen 5, and I've never seen 6 cusps, although theoretically it may well be possible. So I think that we can look at the cusps over here. This one is a fairly symmetrical truncus. Let's see the truncus, the lettering disappears, so you can see the commissural apposition in the region of the center of this truncal vessel. So perhaps, as you can see in the bottom frame, there isn't a major degree of truncal regurgitation. But when you get truncal valves that look like this, frequently there's very abnormal truncal vascularity. Okay? And as I mentioned, not all truncuses don't have a duct except for the type 4, but you can see in type 1 and type 2 truncuses that there's frequently an arterial duct as well. Kind of surprising. Now, here's a bicuspid truncus valve, and you can identify this with parasternal short axis imaging. Sometimes the cusps run at different levels, as they do in aortic stenosis, maybe a back to front or side to side vascular pattern. Now, truncus, Dr. Rudolph talked about truncal stenosis, and I think he's quite correct in that the fact that there may well be truncal stenosis, but it can't be that severe. And one of our problems as echocardiographers at identifying this is that after birth, with this increasing cardiac output, many times this perhaps mildly stenotic truncal valve is putting out 4 or 5 cardiac outputs across the valve, and under those circumstances leads to a gross overestimate of the true pressure gradient across the valve. And here you can see the insufficiency as well in this truncal valve, and in the parasternal long axis, again reminiscent of one of the pathology pictures I showed you, a really quite awful looking truncal valve. And let me just move this away from here so you can get some idea of the truncal valve, and I'll put it in this direction so you can see it here. And thickened, rolled, incompetent truncal valve with incomplete opening. Here is a pathological example of a quadricuspid valve with fairly equal distribution of the truncal cusps with a little central truncal insufficiency. But they're not always that equally distributed, and some of them may be maldistributed. And frequently, when the surgeons go in on some of these quadricuspid valves, they tend to remove the smallest leaflet and maybe suture the leaflets together and do remarkable plastic things on the valves to ensure competence after surgery. And one of the other things, of course, is as you immediately remove the volume load across the truncal valve, the pressure drop immediately diminishes after surgery. So valve regurgitation occurs not only at the truncal vessel level, as we've shown, but also occurs at atrioventricular, particularly on the left side, with this increased volume load with dilatation of the left ventricle and the left AV valve. Okay, I think we've seen that. We'll just move on here. Okay, and so I'm not saying that there isn't such a thing as truncal stenosis. This is an absolutely abnormal and nasty looking valve. The valve domes somewhat in systole, and it prolapses across the level of the zone of apposition into the left ventricular outflow tract across both vessels. And here the truncal regurgitation is confined exclusively to the right ventricle. And of course, we can use standard Doppler indices to measure the decay of the pressure and look also at the abdominal aorta to see the to and fro flow. And I found Dr. Rudolph's explanation of the fact that the pulse pressure is not so large due to the fact that there's less systemic pressure and a tremendous runoff. But nevertheless, when you look at the abdominal aorta, you can see with progressive increase in the degree of regurgitation, quite substantial degrees of runoff as you would see with a very, very large patent ductus arteriosus. Now the VSD, usually as we see here, is the VSD is cradled in the arms of the septomarginal trabeculation, but there may be other associated VSDs, and the VSD is sometimes quite extensive. As you can see here in this four-chamber view, at a posterior section, the mitral and tricuspid valves on the same level, and under that circumstance, the VSD is eroded posteriorly, and now the conducting tissue in a patient with this kind of VSD with the Truncus Arteriosus is at risk during a surgery. Excuse me. So there's the VSD shown. Whoops. So type 2 truncus was the standard type 2 truncus. Sorry about this. And you can see here that when you look at the back, you see the whole truncus coming off the back of the truncal sac. And of course, as Dr. Rudolph had appropriately remarked, here is a neonate that died with Truncus Arteriosus, and look how small compared to the size of the aorta the truncus is as it arises posteriorly off the sac. This is the same type of truncus, a type 2 truncus with bifurcating vessels, and these vessels are situated quite distally to the truncus vessel over here. Type 3 truncus, I'll show you some other examples. Here is the isolation of the right pulmonary artery, and here is a right aortic arch with a left innominate artery with the left carotid, left subclavian, and the left patent ductus arteriosus perfusing the pulmonary artery, as I've shown you here in this figure. And here is such an example of a patient with a right aortic arch. I've just turned the drawing round, as you can see. So the arch is now right-sided arch with a left innominate vein with the vessel coming from the base of the left innominate and perfusing the left pulmonary artery. And it's this particular type of truncus where the coronary arteries are close by that there is a risk for injuring the left coronary artery in taking off the vessels of the back of the truncus. Now, Truncus type 4 is probably one of the most common, and I think I would echo, as an echocardiographer, the sentiments and ideas of Dr. Sanders and Dr. Rudolph, that when you see the ascending aorta in this condition pathologically, it almost looks like that this might be a hyperplastic left heart syndrome with a big ductus. And indeed, that is one of the mistakes that is frequently made about a hyperplastic left heart, is that they call them type 4 truncus. And under the circumstance, the ascending aorta is usually very small, frequently because these patients are 22q11 minus diseases. The subclavian arteries rise anomalously, and therefore the ascending aortic trunk is very small and actually arises as an appendage of the ascending aorta. And here you can see that, if I'll just stop this for a moment for you, and you can look at how small the ascending aorta is compared to the size of the rest of the truncus, and note here a ductus, and this caveat that we mentioned: when you see a ductus, please make sure that you're not dealing with the type 4 truncus, and most of the time you will be. So here again is another caveat to a small aorta. When the ductus is as big as the arch and bigger than the great vessels, and the aorta, the ascending aorta, is very small, beware that you, and there you can see the ductus between the two pulmonary arteries, that you have a truncus with an aortic arch interruption. And in this circumstance, usually the subclavian artery arises from the descending aorta, and when you Doppler the various vessels to the head and neck, you will find a different kind of profile, circulatory profile, in the vessels to the head and neck from the subclavian vessel, and the subclavian vessel will have a lot of retrograde flow in it because it's reflecting the situation across the ductus and the descending aorta. So that can be very useful. in terms of making the diagnosis. If you didn't like that picture, here's another example of a type 4 truncus pathologically with the subclavian artery arising off the descending aorta. Here's the small ascending aorta, which looks like almost an afterthought. And with the color flow angiography, which I like very much, you can see the flow, the size of the flow, and appreciate the volume of flow that goes into the ascending aorta. And here again is another tiny ascending aorta with a big truncal vessel coming off it with type 4 Truncus Arteriosus. All right, let's move on a little bit there. Now, the other variations, sometimes the pulmonary arteries don't develop. Here's a patient who's got a single pulmonary artery which crosses over and goes to the other side. There are other variations here with an abnormal arch and a solitary right pulmonary artery in a different patient. So looking at the pulmonary arteries is also very important in terms of making assessment, and I've just counted the truncal cusps for you on this illustration here. The Rastelli operation we've already mentioned, and certainly at surgery we can we do the transesophageal echoes to see preoperatively what happens and what happens to gradient patch closure. As you can see here, very redundant patch placed across the VSD here, pericardial patch, and we look at see what happens to truncal insufficiency and stenosis. Okay, and assessing the patients postoperatively have all of the problems of conduits. This is a late assessment, and you can see that conduit appears to shrink, often calcifies. These homographs calcify, the valve leaflets become thickened. Here you can see fairly nice branch pulmonary arteries close to surgery, and then later on they sometimes develop stenosis. There's insufficiency, as you can see here, as well as mitral insufficiency that it comes, that you can identify. Here is a redundant patch. And one of the problems with assessing aortic insufficiency is the jet is no longer free. It gets directed, as we saw on one of the earlier examples, towards the right ventricle, except that there's now a patch placed between this, and this then really obfuscates the length of the jet and makes it very difficult to assess from jet length the severity of the stenosis, although the diameter of the stenosis together over the diameter of the aorta is a much more reliable assessment of truncal insufficiency. So let's leave that. Now, so sometimes the regurgitation doesn't get any better, and here's a postoperative truncus, and you can see that red flow, which has the arrow in it, really indicates that there is a substantial amount of retrograde flow still present after surgery, and indicates that, in fact, the prognosis is much worse when this degree of truncus regurgitation remains after surgery, and either a plastic procedure has to be done on the valve or a valve replacement has to be done, and that it's in itself, in an early truncus in a neonate, carries an extremely poor prognosis. Okay, and we look at the pulmonary artery. Sometimes as the patients grow, they get to be small again and can develop stenosis at the site of the origin of the anastomosis, depending upon how lucky the surgeon has been in putting these valves into place. Now, I'll just finish off because we have been talking about coronary arteries, and we were talking about them in the coffee break. Dr. Damien Bonnet has done a study of patients in Paris, and he says 100% of truncuses have abnormal coronary arteries. The study from the two studies that I know have cited 17% and 18%. as as coronary artery abnormalities. And here I'll show you a couple, and one of the reasons why we may have persistent myocardial problems after Truncus Arteriosus. Here you can see the coronary artery right next to the pulmonary artery, very close running the circumflex coronary artery. And in these two specimens that I have for you here, you can see very high coronary arteries. And when the coronary arteries are high outside the confines of the sinus of Valsalva, they frequently intramural. And indeed, here is an intramural coronary running within the wall of the ventricle as it goes posteriorly here. And perhaps that's another reason why, in addition to all of the loading conditions that they have in Truncus Arteriosus, that their coronary arteries may be abnormal because they have a long intramural course. And that's not the only problem, because here is a very abnormal conal branch coming off the right ventricle here. Another example of a coronary artery coming off the back of the coronary cusp and running an intramural course, and here again, and here the high coronary artery. So I think that coronary artery anomalies are something that we need to seek, and we need to evaluate them in great detail. And here are just pictures of the coronary arteries, the right and the left coronary artery running through the circulation. And thank you for your attention. Dr. Hasbani. I'll do it. Yeah. Yes.
For those who will meet us later in the Paulaner Brau house, it's quite near, it's 15 minutes walk from here. We just walk this street in this direction till you get to the Goethe Street, turn left, and then all the way down. And at the border, Goethe Street to Kapuziner Street, there on the corner, there's the Brau house. If you have questions, just come to me before you leave. I show you on the map.
All right, Truncus Arteriosus. I'm actually going to try and go through this relatively quickly to show you guys the examples. As you know, it's not such a common congenital abnormality. Transposition and tetralogy of Fallot are much more common. And so we know a lot more about those abnormalities, but this is commonly found with a 22q11 deletion, and about a third of the patients have that. One of the common things that we can have learned from tetralogy of Fallot is that the RV to PA conduit can be very easily studied with cardiac MRI, as well as the left side of the arch with the neo-aortic or truncal valve and aortic arch obstruction that has been discussed. And so you're going to see a lot of similar information done here as there was in the other last two lectures that we've been showing. And so I'm going to mostly show you the images so you can get an idea of this. This is actually a pretty young patient with Truncus Arteriosus whose parents did not want him to undergo sedation, and so we did real-time images to take a look at the truncal valve, which you can see is not working well. Dilated, quite a bit of regurgitation here. The RV PA conduit is actually widely patent, and that's not actually his problem. His major problem is really that truncal valve. And when you take a look at the truncal valve of many of these patients, you can see in this case it's a quadricuspid valve. The cusps are not all the same size, and you can already note that there's poor coaptation in the center. When you take a look at this by velocity encoded imaging, you can very clearly see the anatomy as I showed it, but you can see these two black dots, almost like owl eyes in the center, in the area where the coaptation is not happening. And this is a nice image to show a surgeon before they go in, because obviously when they stop the heart, they're not going to be able to see this for coaptation as well, as they can see it when they see the anatomy right there. And then they know exactly where they would potentially put their pledgets to try and help this valve, maybe make it a bicuspid valve or a tricuspid valve rather than a quadricuspid valve to try and help the insufficiency. Here's another patient, status post truncal. You can see in this specific patient, the right side is more the problematic side. The left side seems to have a little bit of insufficiency, but not so bad. No dilation. The ejection fraction looks nice. But right here, you're going to see quite a bit of stenosis causing right ventricular hypertrophy and quite a bit of regurgitation. You can analyze these patients very similar to the ones I've showed you before, looking at both the right ventricular systolic volume and the left ventricular volumes, as well as the ejection fraction. You can see here there's mild right ventricular hypertrophy, as well as dilation. The left ventricle is significantly smaller towards the apex compared to the right ventricle. And here you can see the stenosis in the right ventricle almost at the right at the outflow tract where the conduit was anastomosed. You can take a look at these patients by angiography or MRA and take a look both at the right side and the left side of the anatomy. And then you can analyze it even better looking at the pulmonary arteries specifically. You can see where the conduit location is and the valve in that area, and the arch. You can see the dilated ascending aortic arch right at the above the valve. You can also take a look at their coronary artery origins, both the right coronary artery and the left coronary artery. In this patient, they look normal. And you can see patients with different post-operative repair and abnormalities. So this patient obviously has right ventricular hypertrophy and left ventricular hypertrophy from pulmonary stenosis and aortic stenosis, versus this patient that has significant mitral regurgitation with aortic stenosis, and you can see this aortic insufficiency, and you can see quite a bit of dilation. You can see dilation here of another patient, same anatomy occurring. Here's another patient with actually very good results. You can see just a mild amount of regurgitation there, but overall relatively normal truncal anatomy. These patients, just like the other patients, are going to get late gadolinium enhancement. You can see it here in the RV outflow tract, as well here in the right ventricular body, and then here as well in the outflow tract, here more in the septum area. And again, although it hasn't been as clearly demonstrated, the late gadolinium enhancement is going to increase your chances of arrhythmia and sudden cardiac death. We can assess the right side very similar to the tetralogy patients. You're going to look at the right ventricular and diastolic volume, ejection fraction, and so forth to decide if an RV to PA conduit needs to be replaced. And so very similar measurements can be done, as well as the left-sided measurements. So just like you've heard before, the anatomy, especially in these patients as they become older, teenagers, adults, is really going to be the key to using your cardiac MR, as well as your volumetric measurements. And that's it.